It's really a tremendous pleasure to introduce Dr. Amy Tiersten to present to you the best of ASCO. Thank you so much, Amy.
Thank you so much, Shelley, for that nice introduction and for inviting me. And I will start sharing my screen. So I am going to be reviewing some of the abstracts that I thought were most interesting from ASCO in this past June. These are my conflicts of interest, not related to anything discussed in this talk. The first abstract that I'm going to talk about is a study that was a late-breaking abstract that was presented at the plenary session by Shanu Modi. And it was such an exciting presentation that it led to a standing ovation that lasted about 5 minutes, which I haven't seen since 2005, when it was shown that adding trastuzumab to chemotherapy for early stage breast cancer reduced the risk of recurrence by 50%. So there was a lot of excitement in the room. And this is a study of trastuzumab deruxtecan versus treatment of physician's choice in patients with HER2-low metastatic breast cancer, the results of DESTINY-Breast04 randomized phase 3 trial. I will heretofore be calling trastuzumab deruxtecan TDXD. So prior to this important trial, HER2-low metastatic breast cancer was all kind of lumped with HER2 negative, was just considered immunohistochemistry 0, 1 plus, or 2 plus with negative-ish. And if patients were hormone receptor positive, they could receive sequential endocrine therapy in combination with various biologics. If they were BRCA positive, could receive PARP inhibitors, and then pretty much went on to sequential single agent chemotherapy with fairly limited benefit. For hormone receptor negative patients, if they are PDL1 positive, they could benefit from chemotherapy plus checkpoint inhibitors. Again, PARP inhibitors if they're BRCA positive. Another antibody drug conjugate, sazatizumab govitecan, and then sequential single agent chemotherapy of only modest benefit. So HER2-low metastatic breast cancer is defined by immunohistochemistry scores of 1 plus or 2 plus-ish negative. And this is a heterogeneous population with a high prevalence of hormone receptor positivity and without a real distinct biology. Prior to this study, current HER2 targeted therapies had not been shown to be effective for patients with low expression of HER2. And therapeutic options is pretty limited for hormone receptor positive HER2 negative breast cancer, with studies suggesting a progression-free survival of less than 4 months in patients after progressing on CDK4/6 inhibitor therapy, and then limited benefit for later lines of multiple agents of chemotherapy.
And her passion for taking care of the underserved patients is really phenomenal. So without further ado, Maureen, thank you so much.
Well, thank you for that introduction. I'm going to go ahead and share my screen. Very good. So thank you for the opportunity to give this talk. I went through the program and picked out some highlights that I'll go through with all of you. These were, it was hard to make the decision of what to choose and what to pick, but we'll go through each one. So the first talk is here looking at Oncotype DX scores and nodal status in patients over the age of 70 with the opportunity to continue to choose wisely. The Choosing Wisely campaign is really asking physicians and surgeons to really make the correct decision and decisions based on if it's going to change outcome and treatment in terms of patients over the age of 70 and what you would do for their sentinel lymph node biopsy. So the objective of this study was to examine the distribution of Oncotype recurrence scores in women in this age group with clinically node negative, hormone receptor positive, early stage breast cancer, and identify clinical factors associated with a high recurrence score. Just in terms of the background, so we know that there are randomized controlled trials that have shown that Oncotype score less than 25 in women over the age of 50 postmenopausal women with 0 or up to 3 positive nodes in hormone receptor positive tumors do not benefit from the addition of chemotherapy. And what they're showing here is that the Oncotype score was essentially the same among node negative and node positive patients. This data was from 2010 through 2018, and they did see an increase in Oncotype testing over this period of time in both groups. The multivariate analysis was done and trying to understand which factors may actually increase that score to be greater than 25. So grade 3 versus grade 1, PR negative versus PR positive, and tumor size greater than 2 centimeters. And what they found was that the nodal status for women over the age of 70 with these smaller hormone receptor positive tumors may not necessarily differentiate which patients benefit from chemotherapy or not, supporting this idea of choosing wisely and possibly omitting that sentinel lymph node biopsy in this group of patients.
So as you see, Dr. Slayman was the first, then Dr. McCormick, then Chip Cody, Cliff Hudis, and now Dr. Weiner. So I'd like to tell you a little bit more about Dr. Weiner. You all know him, of course. He started his career, at Yale, both an alumnus of Yale College and Yale School of Medicine, and it was the director now currently of the Yale Cancer Center and physician-in-chief of the Smilow Cancer Hospital. He's also the Alfred Gilman Professor of Medicine Pharmacology, and he joined Yale in 2022 after a 24-year career leading the breast program at the Dana-Farber. He's an internationally renowned clinician, researcher in breast cancer, who has led so many clinical trials that have changed the face of the disease. He's been an advocate for building teams of scientists and clinicians to accelerate progress. He is currently the president of the American Society of Clinical Oncology, a member of the scientific board for the Breast Cancer Research Foundation, and he's had multiple leadership roles, including as a scientific advisor for Susan G. Komen, NCI Breast Cancer Steering Committee, over 400 original manuscripts, mentored many fellows and junior faculty, and the big awards. And this one, so the William Silent Lifetime Achievement in Mentoring Award from Harvard. Some of you who are a little bit older, I spent a little time in Boston, and I knew William Silent, who's a surgeon in there, and he was really a remarkable surgeon and mentor and human. The William McGuire Memorial Lecture at San Antonio, the Giovanna Bonadonna Award from the American Society of Clinical Oncology, the Brinko Award from Komen, and more. So I think for him to return to Yale, he'll tell you, I guess, is amazing. And it's so amazing for us, for him to come from Washington today to join us to give his talk on HER2 positive breast cancer. Will it eliminate all mortality? So welcome to Dr. Weiner.
We then have TDM1, which of course for many years was the only drug antibody conjugate, clearly a very active drug where the antibody drug conjugate is internalized, the drug is released. And the nice thing about TDM1 is not only that it is associated with clear improvements in both progression-free and overall survival in multiple studies, but that its toxicity is really quite modest. But the drug that has really captured everyone's attention more recently, of course, is trastuzumab deruxtecan. And that's not only because it works in the so-called HER2 low population, but that in patients who have, frankly, HER2 positive breast cancer, it's a highly active drug. Whether that's because the payload is better, whether that's because the linker is somewhat different from what we see in TDM1, and to what extent it's because the drug itself is able to diffuse out of the cell and potentially have a cytotoxic effect on neighboring cells that may not in and of themselves be HER2 positive. For whatever reason, it is a highly active drug. And in this trial comparing trastuzumab deruxtecan with TDM1, it's not subtle that there is a very, very clear improvement in progression-free survival. And as would turn out, of course, ultimately an improvement in overall survival as well. I think that tucatinib, which is probably the tyrosine kinase of choice now, is a drug that we still haven't quite figured out how to use. It came out at about the same time as trastuzumab deruxtecan. It clearly adds to the combination of capecitabine and trastuzumab, and is clearly very active in patients who have both systemic disease and brain metastases. But where it slots in, I think, is a bit confusing.